This week on the Backtable Podcast.
In my opinion, and that's just my opinion, is I think the oral agents are probably going to be the more widely used modality, again, because of convenience, things like that. So we've incorporated it. We talk about it now. It's the ease of use of getting it is extremely pleasing to our patients. I'll be honest with you, I thought at the price point, I was a little concerned that patients would not go for it. But with everything else kind of going up, the price difference really now is really about $20 to $30. Plus they get it sent to their home. I'm like going, you know what? It's really been, again, a surprise, but at the same time, as a treatment, I think it's an effective treatment. It's great, but also I'm surprised that patients really are gravitating towards it right now.
Hello everyone, and welcome back to Backtable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsors. As a doctor, you strive to offer the best care possible for low testosterone, but traditional forms of treatment can weigh your practice down with time-consuming administrative tasks and prior authorizations. That's where KYZATREX comes in. KYZATREX is a cash-only, FDA-approved oral form of testosterone replacement therapy that simplifies prescription management for you and your patients. It eliminates administration pain, avoids the mess associated with gels, and eradicates transference risk. Plus, it enables revenue generation for your practice without the hassle of insurance processing. Discover how KYZATREX can transform TRT in your practice. Learn more at KYZATREX.com. Now, back to the show. This is Jose Silva as your host this week. Today we have Ken Mitchell. Ken is a certified physician associate with 29 years clinical experience overall, and with over 26 years of experience in the male sexual dysfunction and infertility. He received his master's in physician assistant at the University of Nebraska Physician Assistant Program. Do you want me to say the date?
It's okay. You can say that. I'm proud of that. Sorry. Yeah.
So he received his master's in physician assistant studies at the University of Nebraska Physician Assistant Program in 1995. Ken is currently a fellow of the American Academy of Physician Associates, the Urology Association of Physician Assistants, an associate member of the Sexual Medicine Society of North America, board member at large for the American, and also board member at large for the American Society of Men's Health, and APP section editor for the Journal Review in Urology. Ken was inducted into the Pi Alpha Physician Assistant National Honor Society in 2016, and is the 2023 recipient of the American Urological Association APP of the Year and the 2023-2024 Plan of Care Network Top PA in America. Those are big accomplishments. Ken practices at the Erlanger Urology Men's Health and Reproductive Medicine Clinic in Chattanooga, and is the co-founder and CEO of GUYnecology Men's Health Association, a non-profit organization dedicated to men's health, provider training, consumer education, health promotion, and research. Impressive resume, Ken. Welcome to Backtable.
Thank you for having me.
So Ken, I mean, even though you have an impressive resume, I definitely want for you to talk about yourself, start your journey. How do you venture into men's health, and just talk about a little bit of how you became engaged into men's health and your journey as an APP.
Well, again, thanks for having me. It's a real pleasure. Yeah, my journey is a very unique journey. I can honestly say I was not looking to go into men's health. I think men's health found me. There were some personal things that happened along with just the fact that I was practicing. And like many people, that one day in 1998, in March of 1998, that little blue pill came out, and it changed everything for everybody. I had a big interest in vascular medicine, cardiometabolic disease early in my career. And this pill came out, and I started to read more about what it did and how it worked. And I thought that was very unique and interesting. And then all these guys were coming in with these problems, and they were basically the same guys that, we talk about today, but we didn't have the connection yet, but they were all in my hypertensive, diabetic, dyslipidemic guys coming in. And that associated with me really recognizing the lack of care that men were engaging in, that we were promoting, and even, trying to even tell our guys, encourage them to come in even as providers. We're doing such a good job. And then had several close friends of my father who all were diagnosed with prostate cancer at a very early age and, essentially succumbed to the disease. It just shouldn't have ever happened. I know that now. I didn't know that then, but, it was just really from lack of engagement in healthcare. So, and, it was perfect. As a PA, our jobs are really all about education and really kind of keeping that connection with the practice and between the patients and the physicians that we work with. And so it was just a unique fit. Doing it in the general medicine space, that was a little tough. In urology, if I have a diabetic patient, who's got ED, I get rid of him. I said, you got diabetes, you need to go see your primary care doc. Problem is in general medicine, if I find out they have ED and they've got, their diabetes is out of control, I got to manage both.
Ken, let me ask you this. So your passion for men's health began, you were working as a urologist at that time with a urologist or?
Multi-specialty group.
So it was before that, okay.
Mm-hmm.
And then you say, okay, so this is something that I like to enjoy, to explore, to help. And what's the process in at that moment in your mind, or you as an APP, how can you get more engaged in that field?
So just fortuitous, I had said, boy, I wish I could do this full time. It was really, I carved it out in my practice. I sort of segregated it in my practice. What days of the week I did men's health care. And then I said, boy, it'd be great if I could do this all the time, every day, all day. So I saw a job posting on the AAPA website for what was then Metro Urology up in the Twin Cities in Minnesota. And I reached out to them, and they reached out back to me real quick, actually shockingly fast. And sometime between the time where I said I really wasn't serious yet, and I said I'm really not interested. But anyway, they called me back within a few hours after I told them I wasn't interested, after I'd spoken with the HR person. And next thing you know, I'm up there for an interview, and really, literally the rest is history at that point.
And it was for men's health, or it was just for APP as in a urology office?
It was for men's health. So
specific, okay.
Yeah, they really had already had 4 APPs working for them. And they had already started doing what a lot of people are striving to do now, which was to have your APPs doing very specific things in the practice. And so they had an APP dedicated to stone work. They had some that were patrolling the hospitals, taking care of all the hospital consults during the day. And then there was female urology. That was it at the time, and then it has since, of course, exploded over the years with that. But, I was one of the few people I can honestly say was really working Monday through Friday, just doing men's health, didn't do anything else.
And essentially, what was the job at that time for you? When you got into the practice, you want to dedicate yourself to men's health. Was it a matter of, hey, we're going to do, like the urologist, we're just going to do implants, or what was it, testosterone? What was the approach at that time for you? How do they wanted to use you?
Originally, it was just to treat all the ED patients that were coming in, just that were referred, and there were a fair number of that going on. And then testosterone was really starting to take off then. So this is 2005 now. Things started, really taking off then. And so they already had a fairly large number of patients coming in. And probably the one thing that changed my trajectory, I laugh, I said I had about like a 3-month, what I call my honeymoon period, where I didn't see a lot of patients. By today's standards, I maybe saw, a dozen patients at first for that first 3 months a day. But then I went out and I started talking to the primary care referrals within the Twin Cities area. And I could speak to them in a manner in which they were used to hearing people talk about diabetes, because I'd managed it for years. And I said, yes, so here I am. I'm this internal medicine guy hanging out at a urology office, and now I'm getting to marry these things together. So that changed everything at that point. And then obviously there was a lot of prostate cancer work being done. And so we started devising ways in which I could take care of all of our patients post-prostatectomy. We invented a lot of really cool things back then. A lot of what people talk about shared office visits. I was doing that back. We started in 2008. I did a preoperative course where I was the person I provided this information to these patients. We had to conduct that twice a month because of the volume. And basically what it allowed me to do was start their care. I did some back work on the patients. So everybody that was in this course class, as we called it, I had already done some work on their charts. I'd like to see what was going on. I knew when their surgery was scheduled. And we had very scheduled, laid out care for them before they even went in and had their procedure done. And then what that did was soften the blow for me. I knew I'd have to see them afterwards, but, I was one person. When you got 12 surgeons doing prostatectomies, if anything, for your own survival reasons, you figure out ways to orchestrate that efficiently. And so, we were able to do this. So, necessity was the mother of invention in a lot of those things that we were doing. Let's do the volumes.
So Ken, you were providing the education to these patients in terms of sexual side effects, everything, or just purely about the sexual side effects?
Sexual side effects and the incontinence. And so we just talked about all of it. So here's what you can expect afterwards. Here's what's going to happen when you have your surgery. Here's what's going to happen after they, take your catheter out. Here's when you come back in. We had everything really, really well laid out for them. So they knew exactly what to expect. And that's one of the things I'm really proud of. One, to be a part of a practice that was forward thinking like that. And then to be able to put my own spin on that was really good. And we saw the effect. Our patients really felt empowered and were thinking about life after they had their surgery. And we were able to direct that. And then if you go to the end result, if you will, so because we engaged with them so early, patients that were not progressing or they were not responding to any penile rehab afterwards were easily transitioned to implant surgery. And we found out by, again, having this very structured plan that we had for our patients, we have very few people back out of having an implant. In fact, the companies came to me and I didn't even know that was a thing until they came to me, because I said, gosh, our guys never back out. It turned out it was just really about consistent engagement. Is really what it boiled down to. And I was very busy. I saw anywhere from 120 to 150 patients a week.
Yeah, that's busy.
Yeah. So taking care of, but I wasn't burned out dying or, doing it because, like I said, after a while, the need is there. So, you become very solution oriented. Like, how am I going to do this? And let me tell you, there was a small army of people that were really very, very committed and integral to making it all work. So it was great.
And Ken, when did you transition to a more leadership role in terms of being president or being in different organizations? Was that something that you started early in your career or that came afterwards?
That came afterwards. The practice was really, really supportive. What I consider very early adapter in using APPs in the manner in which they did. And part of that also included was the opportunities that if you could do anything in leadership or if you could do anything with their professional organizations, you should do that. And I would say for me, I was already, 10 years down the road, at this point. You start thinking about, all right, I can't be the only one. There's other people out there. So what can I start doing to make a difference to make sure that other people find themselves, constantly trying to figure things out. So we, there's lots of patients out there who need testosterone. There's lots of patients out there that, need treatment for erectile dysfunction. But truth is, we don't get a lot of training in that area as PAs or as nurse practitioners either. We talk about this all the time. So we come into the urology with very little urologic experience. And, obviously there's some challenges that come with that for their busy practicing urologists. Supposed to be a solution, but we're it's like getting new residents,
and for you, I mean, when you started going back to those first month at the new job with the urologist, how important was that mentorship from the urologist, or where did you get the mentorship at that time? Was it reading, education?
It was a combination of all those things. It was reading. Even before I joined, I was already reading about. I was reading a lot of urology journals, and I said, full disclosure, I was working, before I was a PA, I worked in surgery research at the University of Nebraska. So I've been around surgeons, I've been around the urologist, the transplant guy, everybody. So I was already kind of in that mode anyway. I was always searching for answers for anything. So it was a combination of that, and then I would be remiss if I didn't give a lot of credit to, and I can name them all by name, the physicians at the Sexual Medicine Society of North America were very instrumental in teaching me and being willing to let me come visit them to see firsthand some of the things that I was reading about. I had to basically make my own clinical rotations based upon my reading, but they were all very open and supportive to that and were extremely helpful in that regard.
Good. And you mentioned about the clinic for prostate cancer and talking about erectile dysfunction. When did you start incorporating testosterone into your practice?
So testosterone was right away.
Right away, okay.
Right, because that was easy, right? We already had people. Interestingly enough, I mean, the big surge at that time was, the topicals. Everybody was either on androgel, and we saw some others come along, and then I saw, Avid come along, as far as injectables go, and you get,
So this was late 90s, early 2000s.
Yeah. So I saw, oral testosterones come and go. Now they're back again, right?
Let me ask you this, Ken. I mean, at that time, you had baseball fans, so you had Canseco, you had Maguire, you have all these big names, Barry Bonds. I mean, did people at that time ask you about it? I mean, or was there some controversy regarding testosterone use?
Oh, sure. I mean, I'm in a major metropolitan city. Everybody's watching it. Some of those guys, victimized the Twins, right? When
yeah.
As far as baseball players go, a lot, even the college athletes. I mean, I was a college athlete, a long time ago, where things were it was a wild, wild west back then. I mean, you couldn't, the short list was who wasn't injecting, right? Wasn't on T back then. So you're still seeing a lot of that. Probably the thing that was more concerning, I'd say, around the time when I went up there, was I started to see more rampant use in younger athletes, high school age, things like that. So we're seeing a lot of that. So yeah, testosterone was right away, and we really found ourselves having to go and educate our referring providers, patients. So we were doing a lot of that, and also at that time too, here came Testosterone. That jumped into the fray too at some point, and so there was a lot of that, and I found between Avid and the Testosterone and all the other things we found ourselves doing a lot of procedures, of course, around that as well. So that was a new.
So and how did you engage yourself into doing a new procedure? I mean, you haven't done that before. You say, I want to start putting Testosterone. Did the urologist does it first? You started doing it. How does that synergy works?
So full disclosure too, again, I had a background in surgery already. And in primary care, I put in tons of Norplant. This was no different than doing that.
Okay.
So, yeah, I didn't, hopefully I don't scare anybody, but I didn't have one urologist teach me. In fact, I spent a lot of time teaching a lot of urologists how to do it just because I had that experience more than anything else. And I subsequently, of course, taught a lot of my APP colleagues over the years, as their roles were expanding in different practices, started doing that.
So essentially, for you, it was just being up to date, going to the meeting, seeing what's out there, and just implementing into the practice.
Yeah, and like I said, I was in very fertile ground to be innovative in that regard. And, I think there's a guiding principle that all APPs should have, and that is, if we can, I should be doing as much as I can legally and competently in the office that allows my physician to be doing those things that I can, going to the OR, doing more complex procedures, things like that. That's the perfect marriage, if you will, of an APP and a physician.
And Ken, so you started, so at that time it was a lot of gels, injections. So just go through the workup of that patient with low testosterone. At that time, what were you doing? Just doing labs? Just we'll go through that patient when he arrives to the office.
Yeah, so that patient comes in the office. Of course, he could be new or again, or existing patient on testosterone who has really not had confirmed diagnosis. Of course, then we would get symptom scores. So I was a big advocate of using the Q-Atoms, to quantify their symptoms, if you will. And then, of course, getting the morning testosterone labs was extremely important to confirm the diagnosis. I kind of find it funny today. People find that, real labor and a pain. But, you look back textbooks from a long time ago, that's how you confirm the diagnosis, So there was a lot of that. And then I simply was in charge of simply prescribing and managing that patient. Again, because I had a research background, I found myself, I behaved much like an academic in that regard. So I was setting up protocols, things like that. So if a person was on a topical, their lab intervals were different than somebody on injections or than somebody on Testosterone or Avid. And so we had all those things built in just because, again, I didn't want to be buried doing that. So that's really how it was really about that simple. We kind of, we worked through things with protocols and, what people now refer to as clinical pathways.
Because right now, it's easier for us. Everything, there's guidelines. You go to the GUYnet.org and everything is set up. So it's easier. At that time, you have to do your own research, see what works. I like this better than this, and then go from there.
Yeah. And my primary care roots helped a lot because that's a lot of what you do, right? You kind of do a little everything, You're, jack of all trades, master of none, right? So you're doing a lot of that kind of stuff. And that drives how you approach these things. So, but the practice let me do that. That's basically what we did. And then there were some insurance or some payers back then that mandated that the physician see the patient, after so many visits. Same thing. We built that into our pathways. Just said, I might see them as a new patient. I'll get them started. They're stable. I want to visit with the doc. And I got busy enough that some of the docs I had no control of their schedules, but they were pretty smart in that they would sort of set their time. It's like, here's my scheduled day for all the PA follow-ups I got to do, and I know it was their favorite clinic because everything was done. They just kind of like, hey, what's up? Is
that true to this date or that you haven't heard? I haven't heard that I need to see the patient, but I'm not paying attention to what the insurance say. I just go and show up to the office and see whatever.
Yeah, no, we don't have that. Fortunately, we don't have that kind of oversight anymore or even pressure from the insurance companies anymore, which is great. So you'll never see somebody who's been a PA as long as me refer to the past as the good old days because they weren't.
And as your testosterone evaluation or treatment pathway in algorithm in your mind has changed throughout the years?
Sure. We've got new things, right? What I didn't do before I came into urology, I wasn't using things like SERMs, and I wasn't, or even, aromatase inhibitors, things like that. I just didn't have to or didn't even think to. In fact, in primary care, if that happened, if I saw something going on like that, they'd be referred to endo. If I could find one that would take the patient. But it was, now, since we're the custodians of that now, it's much, much easier. And again, probably more honing in on the approach depending upon what the treatment modality is.
You mentioned before the controversy in terms of high school students and testosterone. At that time, was fertility an issue at that point or something that you guys addressed?
Yeah, we addressed it for sure. The abuse is a funny thing. Even between modalities, I believe I've listened to other people lecture, and I'll mention other podcasts you've done I've listened to on the subject of testosterone. Just the difference in how somebody feels on an injection versus on a pill, on a topical. Even little nuances like that, can drive whether somebody's going to abuse it or not. Things of that nature. So, you have to be very upfront, communicate very well, draw some lines in the sand, and only for those people that are abused. Most people, if you're just upfront with them and you really educate them and you really explain to them the hazards of abusing this, the long-term effects, they tend to fall in line. The one thing I think is really challenging today, it's really hard to hear when it happens, is we do get some of these guys that are fairly young in their 20s, early 30s that were started on T, probably shouldn't have been. And now they're having fertility issues. And, trying to pull them back to get them where they're able to have kids can sometimes be really challenging, as you know.
And in your practice, that patient that has fertility issues, what do or that doesn't want to mess with fertility, what options do that patient have?
So certainly we have, although it's cost prohibitive now, but we have Clomid, because we can't get generic anymore. We had HCG injections, again, very difficult to get now. But we have those available to our patients. And that was primarily all we would be using, some combination thereof. I know there's lots of studies out there now looking at the different treatment modalities and their actual impact on infertility. Some may be more favorable than others in those patients who have true hypogonadism, but we don't want to, impact their fertility. So I know we're looking at all those things now.
Yeah, definitely. I think from what I heard is the new modalities, the short-acting ones, it's probably the best way to go in terms of keeping the access and not messing with future outcomes with fertility. So Ken, so how how's your practice evolve in terms of, the incorporating insurance, all that? Because there's a lot of new things out there, but most of the time the insurance won't cover it. So how do you talk to the patient regarding, hey, what to expect regarding coverage?
So coverage for my care, coverage for testosterone, cover for ED medication. There's, it's a discussion that, you're having all day, every day. Right now we have things like, GUYnecology out there. We start talking about prescriptions for a lot of the treatments that we have. That's lowered the cost a lot. Although, even those costs are creeping up. The insurance companies are making it difficult, for all of us to get paid, and also for the patients to acquire drugs. As you know, we've got, the oral medication, now oral testosterone. KYZATREX has basically said we're not going to mess with insurance companies at all. We have a lot of our patients, when they're doing even the ED medications with GUYnecology, they're just paying out of pocket. People are kind of just getting used to that value proposition now that, it is, what's your convenience worth, anymore, and your ability to consistently be able to get the medication and treatments that you need. So, we are taking a lot of that in consideration. We're taking care of these patients now. And I hate to tell you, I probably watch this a little bit way more than I should, but generally about September, I start looking at any kind of changes that might be coming on the horizon, try to get ahead of it a little bit, if I can. I'm never 100% on point, but I get, it's not, the brick to my forehead isn't so hard in January when things roll around, just by doing that.
And for that patient that has low testosterone, you tell them, hey, this is what there's available. Do you try to push them towards something specific, or you let the patient decide?
So it's interesting. I provide a lot of information, but then my caveat is usually this. I said, I'm going to run through all the different treatment modalities you have available to you. My thing that I want is I want something that's going to give you consistent delivery, that you will consistently take, and that you will get consistent results. And I said, if we can get those three things in line, then that will be the best thing for you. So as you know, there's lots of reasons somebody might choose, topicals versus injections, things like that. But, at the end of the day, they can choose something first. If it's not effective, or they're not consistently doing it, that, of course affects things. Then that's where we'll have to go. All right, we got to make some changes here. So that's what we'll do.
Let's dive into the pills. Have you been able to incorporate them into the practice?
Yeah, game changer. A real game changer. Again, I've been around long enough to remember when the original oral agents were, liver toxic, and I watched them, finally get pulled off the market. They were in effect, they were dangerous. For people to be on, and so the fact that we had these three agents come on board, one unfortunately had to come right before the pandemic, so I knew it was out, never got to write for it initially. Then we had Tilando and KYZATREX come along. And in my opinion, and that's just my opinion, is I think the oral agents are probably going to be the more widely used modality, again, because of convenience, things like that. So we've incorporated it. We talk about it now. It's the ease of use of getting it is extremely, pleasing to our patients. And I'll be honest with you, I thought at the price point I was a little concerned that patients would not go for it. But with everything else kind of going up, the price difference really now is really about $20 to $30, plus they get it sent to their home. I'm like going, you know what? It's really been, again, a surprise, but at the same time, as a treatment, I think it's an effective treatment. It's great, but also surprised that patients are gravitating towards it right now.
In terms of how the patient gets the medication, do you guys have your own pharmacy, or you send them to, for example, KYZATREX pharmacy?
Right. So we're at Erlanger as an academic, health center, health institution. And so our next step is to get it in our pharmacy. Right now we're sending the prescriptions directly into the pharmacies that are available that we know carry it. Now that's even cool too. You can send it directly through your EMR. It's easy to do it. It's like writing a prescription in Walgreens, and the patients are getting contact and they're getting their medication very easily. But that's our next phase, actually, is to get it into the pharmacy where we are.
And do you talk about pricing with the patient, or what do you?
Absolutely. I'll flip my phone out on a heartbeat and I'll show, hey, here's the good RX prices for this. Here's what the price is for KYZATREX. And I'll say, this is, here are your options, and again, I let the patients decide. And so it works out really well. But I think it's key, if I were to advocate for one thing, is my experience, particularly in the larger practices, the larger service lines, having it in your pharmacy is key, because that's just one more step to getting into the patient's hand much faster.
Yeah, I'm in a health system in Orlando, and that's definitely, we have had the talks. We haven't done it, but it's definitely in the talks. In terms of benefits, you mentioned the ease of just taking a pill. What other benefits does the pill form of testosterone bring to the patient?
Well, lower side effects. I mean, I could keep it that simple. And because it's the way it's delivered, there's a consistency. You don't have these big peaks and troughs, which really to me is that's the thing that I look at, across the board. I don't care what we're talking about. I'm mindful that, there are different peaks and troughs with these different modalities. It's pretty consistent because of the quick in and out of the oral medications like KYZATREX. And so we see those patients really get stable quick, don't have to have a lot of dosing adjustments. Some of the people that I've switched is really because they were having side effects or having trouble with maintaining consistent doses. And therefore, I refrain from using adverse effects when I talk about somebody with erythrocytosis. That's dose related, but if you can't control the dose, then you would expect that to happen. And those folks that I've switched in the past, and now again that I have again got some experience now with KYZATREX, that's what I'm seeing. The same thing is I'm not seeing that myriad of issues that can come with the other modalities.
Have you switched patients from injection to pills?
Did it?
And in terms of, because I'll contrast it from when you switch a patient from injections to gel because they don't want to poke themselves.
Right.
Usually they don't feel it.
Right.
So they don't feel what they used to with the injections. With the pills, does that happen or is it less frequent?
So, as I can't compare it to other times I've done it because I haven't done it enough, but so far I have not heard that back. But that's always an issue, right? Like I was saying, if somebody's on a super therapeutic dose of injection, and they're not feeling jacked up on it, they're thinking something's not working, right? So, but so there's that part is a combination of that education saying that's not supposed to happen.
And for the follow-up of these patients, are you ordering liver enzymes, or do you need to order liver enzymes for these patients?
I will at baseline, and then I might do them annually. I know there's no real set plan on that, but part of this too is, again, I had a background in transplant surgery. You have to impress me a lot to really damage somebody's liver to where I'm like really concerned about it. So, but again, I don't go outside of guidelines or anything like that. But getting those initial ones are nice, and then you can check one after somebody's on it and they're stable, and then I think annual is fine after that.
What do you usually do for follow-ups? In terms of labs?
So we have two separate kind of panels. Our regular follow-up panel basically includes, for us, we'll check a CBC, we'll check a total and free testosterone. We will check LH and FSH sometimes. It just depends on what else is going on with the patient. So that would be one of our other specialty panels, but that's really like our normal follow-up. So we'll know what their T levels are, we'll know what their hematocrit is. And then for our guys that are, of age for prostate cancer screening or they're at risk, then we have another panel that includes the PSA as well at the appropriate intervals.
You mentioned free testosterone. Do you order to see something specific? Because it's very difficult to try to increase just that. So why are you looking for when you order it?
So initially when we're looking for it, obviously we're looking to see if their free is low and they've got normal total. Of course, then you start looking at their SHBG and their albumin, right? So you just want to know if they're binding up a lot of it and they have very little active testosterone. So that's usually what we're looking for there. As a follow-up though, just making sure again, if it's annual, am I looking for any big swings or anything like that? Well, no, what can I tell anybody from one year to the next? Nothing, right? So...
Yeah, because I stopped following the free testosterone because then sometimes I had patients that the free was low, they were feeling fine, And and the total was higher, but they're feeling great. So then what to do? It created some problems. So, but that's just me.
Yeah, I hear you. And I will tell you that the one thing that's tough is let's say somebody starts having liver problems. I mean, they may start having trouble with, increasing their protein, levels, and then therefore free dropping, then become symptomatic again. That can happen. Can you follow them around all the time and find out when that's? No, you can't. So, annual is good enough. If they tell me something's happened, that along with those Q atoms, something's changed. And we always leave the door open too. We say, like, if something drastically changes between the time we see you, and the next time, then that's, we'll address it. The other thing we did too, though, was incorporating telehealth was really important for us with testosterone. So we alternate the visits, live telehealth, as long as the guy's stable. And that works out really well for us.
Yeah, and you mentioned that. So I started doing just telehealth for follow-ups for testosterone. But there's some insurance, they want the patient to come sometimes to clinic. But yeah, telehealth I think is perfect for just follow-up if there's no other issues. So Ken, let's talk about gynecology.
Absolutely. So gynecology was really born out of the question you asked me earlier, my journey. As I started getting further down the road in my career, many of my colleagues were reaching out to me at the time, especially when I was APP membership chair at AUA. And I was hearing about the many challenges that my colleagues were having around the country. And interestingly enough, a lot of them, of course, felt like the need to approach me about their role in delivering men's health care in their practices. And what I was finding was a lot of them did not experience the same, journey that I did, where I had all these wonderful physicians, who were kind enough and receptive to teaching me. And I will tell you, the lion's share of them did not have an APP. I mean, they could have just said, "You're not a doc, you can't come here." Could have easily have done that. And these guys are giants in the field, and not one of them said no. And so there I was, as I was going along and I'm hearing more of these questions and people asking me about it, decided that, hey, this was something that I could start doing. And I started training APPs, one-offs around the country. They would come to my practice and I'd spend some time with them and keep in communication with them and work with them. And then I was coming back from a trip in Memphis. My soon-to-be wife and I were talking, and she asked me, she goes, "So if somebody ever asked me exactly what you do," she goes, "what would be the elevator pitch?" And so I gave her my little quick spiel. This is what I do. And she's the one who said, "Oh, like GUYnecology, GUYnecology." And I was like, "Are you kidding me? I've been doing this long and I never thought about it." And I embraced the term for a couple of reasons. One, I've heard other people say it, but now I latch onto it and say this could mean something. And really what I wanted to do was I wanted to take advantage of something that was catchy, but it was the storefront for a bunch of really high-level educated people who could deliver good quality care, but be as catchy as every low-T center or anything else that was out there. And what really, really made us take off with it was, one, we said, okay, we're dedicated to APP training. We want to make sure my colleagues could come. We have an annual meeting. We're going to now move towards more offerings, more periodic offerings and things like that. And that's not to compete with all the larger AUA and SMS and all that, but I think if I could have a network of APPs, like I had a network of physicians, and there's a lot of those APPs that are out there now, even that are people that I trained in the past that are out there now, we could bring them together under one roof every so often, or at least even when we're not together. There's an outlet like I had to reach out to them, then that's what we would do. But what was really interesting, how we started jumping to consumer education, which this is new this year, we've never done it before, was I'd be walking around with one of these T-shirts on, flying somewhere, whatever.
Show the T-shirt.
Oh, so there you go. You see it?
Okay.
College. So we would be flying somewhere, and I mean, my goodness, we would stop people getting on the plane. The flight attendants would ask, "What's that all about?" People already in their seats would be like, "Hey, tell me about that." And what I learned to appreciate was I knew I had good answers. Now I knew I had good things to tell guys to think about. But what the word did was it made people actually ask for a change. So it started the conversation, and I thought, man, that's 99% of the battle, right? Just get them to think about it. And so then we field tested it when so I'm in Nashville. We field tested it during the NFL draft. We walked around with the T-shirts on, and there was a different T-shirt. We hadn't gotten the new fancy logo and all that at that point, but we walked around, and that phenomenon was we had 200 cards, which were gone in about an hour. And, at that point, I still really don't have a lot of content on our website or anything for consumer education, but it was just like a natural thing for us to progress to now. We said that's what has to happen next. So,
and are you still, teaching APPs, or is just going to be purely consumer, or it depends on what happens?
We are, shameless plug, November 8th to the 10th will be our next live meeting here in Nashville. And, we have gotten tremendous support from industry. And like I said, I love it that, for me, I just want everybody to be able to go and do this kind of work and enjoy it as much as I have. And honestly, I also look at it like this, you as a urologist, there aren't that many of you left, and the population and the patient demand is growing. I know, and I've written about it, I've been on the AUA papers, we are looked at as one of the solutions, but it's really important that the challenge of training APPs to come in and be functional in your practice as soon as possible is in fact a challenge. And probably if we can just develop a network and do things like I'm doing now in other places, which they are at SMS, and I know there's fellowships popping up everywhere, we will help make that transition much smoother for all those coming after us. So, and that's it for me at the end of the day, and so stay tuned. I'm sure there'll be some antics. I've often joked, I said I could probably just take my phone and record every interaction I have when somebody sees this T-shirt. And that's probably all the education I need to put on the website.
Cool T-shirt.
Yeah.
So Ken, any last words or actually I'm going to ask you words of advice for a young urologist or somebody recently graduate that hasn't worked with APPs. What will be your word of advice for that urologist?
Educate yourself about how APPs are trained. That'd be number one. Then number two, as you're ramping up your practice and you're working on getting busy and being productive, start thinking of ways you can clearly fill gaps in your practice with utilizing an APP. And then don't think of it as the person who's coming in to, be your gopher. Think of it as your new team member. Because at the end of the day, I will tell you again, I'm giving a lot of credit to the folks at Minnesota Urology. They're called now. One thing they did a tremendous job of is when people saw me, they knew I was part of this greater team. So the patients, the best feedback I ever got, I never got this in primary care, by the way, was that they said, I really appreciate the fact that I have two of you looking at me at any given moment. I have two sets of eyes that are involved in my care. And that's huge. And, so you want to think about it like that, bring in a team member, make sure you got clearly defined needs that you can have met by using an APP, and then strive to really make sure that everybody sees you as a two-headed monster, and nothing but good things can happen.
Excellent. And we have some APP listeners as well. So any last words for the APPs out there?
Well, I'm rounded third head at home, so I'm gonna hopefully find myself doing more of the training. I would encourage any of those that are in the role of men's health, please come check us out. We'll do more and more and more, and we really want to make sure that we get that next generation ready to go.
Good. Anything else, Ken?
Nope. I think I'm good. My voice held out. I'm really happy about that. So
no. Thanks for being in Backtable, and hope to talk to you soon.
All right, sounds great. Take care now. Thank you for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _Backtable on Instagram, LinkedIn, or Twitter.
Backtable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.